Hello and good morning everyone. I'm Dan Kinikini with Vascular Surgery, and today in Skills Lab we're going to work on AV fistula anastomosis. So creating an AV fistula for dialysis access. Here we have our arm model, and for this example we're going to do a brachial artery cephalic vein AV fistula. And typically I'll do that with a transverse incision just above the elbow crease. So I will mark out the incision here. It's acceptable to do a longitudinal incision as well, but when you're near the elbow crease, you have to watch and make sort of a lazy S type incision or be completely above the joint to prevent contracture. So I usually like to go transverse. And in our model here, we've got the incision marked out, and we'll make the incision through the skin typically. All right. And then normally we'll pick up with adds and pickups, and your assistant will pick up the other side, and we'll just use electrocautery to go through. But in this model, we will just, thank you sir, we'll go through the subcu fat with our knife. And very fat arm on this person. Alright. Okay, so we'll then use our self-retaining retractors, our Wheaties, and we'll spread the subcutaneous tissues, and we will finish our incision here, gain maximum exposure through the skin incision. And again, normally we're using electrocautery for this. Okay. Alright. Use another wheat laner. And in the bottom of the wound here, you can see that we have, or Peter, has marked the vein in red and the artery in red and the vein in white. And so typically I'll mobilize the vein first, and the reason for that is you want to be sure that the vein is of good quality, and if the vein is not of good quality, you might as well move somewhere else. Typically you know that by ultrasound preoperatively, but sometimes there are surprises. So in any vascular dissection that's not a redo, there's always a thin layer of kind of periadventitial tissue that you need to mobilize. And this model actually works quite well for that. As we were talking, I did a case with Peter over the weekend, and we said, hey, this is just like the model when we mobilize the vein. But you can see, I hope you can see, there's a clear layer of tissue over the vein. And so we grasp the vein by the adventitia, or your assistant can do it, but I'll do it here. And then we use Metzenbaum scissors to sharply start the dissection and get that periadventitial tissue away. So just a sharp incision like that, and then some traction and countertraction, and then just a combination of sharp dissection and a little spreading technique. That way you can look for branches. If there are branches coming off, they can be ligated, and stay as close to the vein as possible. So we're mobilizing it, and you do the end closest to you, and then here's where your assistant comes in, and they'll grab that periadventitial tissue, give a little countertraction, and then you can use your sharp dissection technique to mobilize the other side of the vein. And then once you have a fair segment mobilized on either end, a technique most people use will be to get under the vascular structure, vein or artery, because you've mobilized the periadventitial tissues laterally and medially, and then you can get under the vein, do a little spreading with the right angle as such, and your assistant can pass you a vessel loop, which most of us use to sort of minimize the trauma to the vein. You can pull the vein, retract it in different directions with a vessel loop. Okay, perfect. All right, so most AV fistulas are done in an end of vein to side of artery fashion. So that means we have to mobilize enough of the vein distally to ligate the distal end right here where I'm showing with the scissors, and that will free up the vein, allowing you to swing it over to the artery. So we're going to do that right now. There's my right angle here. So I will pass the right angle under. The assistant will hold the tie, and then the assistant will kind of put a little tension on the vessel, or you'll tie. You want to tie it? Go ahead. All right, so we're going to form the loop up, and this is another technique in vascular that's pretty important, is really to learn how to push that knot down. And you have to move that knot as distal as you can with your finger, And really try not to pull up on the vein, because when you're doing it on a very small vein or a small artery branch, if you don't learn the technique to form the knot up high and push that knot gently down toward the vessel, you'll end up avulsing branches at inopportune times and generally making a nuisance of yourself. So there you go, very good. So he's got that vein ligated distally, and then I'm going to take the scissor here and just divide the vein. Most of the time we don't put when we're doing fistulas, we just leave that end open. There are valves in the veins, and if the valves are competent, you won't get significant back bleeding here. If you do, you put a little bulldog clamp on it, but most of the time you don't really need to. So we've got our vein isolated. I'm going to cut the suture on the distal end, and boom. So now we have a dissected vein that is very mobile and can be swung right over to the artery to perform the anastomosis. All right. We'll take a pause for a second. Okay, now we will prepare the artery. So again, similar technique with grabbing the adventitia of the artery, and again, tension, counter tension, and incising that periadventitial tissue using kind of a spreading technique. Oh my gosh, I made a hole in the artery. They'll be bleeding right now. Let's pretend I didn't do that. That could easily be fixed. We could fix that with a small suture, but we won't. All right, so again there, and then Peter will grab the artery there, and I will dissect off the periadventitial tissue here. Okay, and again, we'll use that vessel loop technique. Right angle. I put that right angle. Thank you. All right, so we'll get under it with the vessel loop. Again, you can spread those posterior tissues, grab the vessel loop, clamp that. Okay. And again, oftentimes there are small branches that if we encountered them now, we would be careful to identify them and ligate them between silk ties, typically 4/0 silk. All right, but we have artery out here. Again, you can see how I'm tensioning that vessel loop and using it to my advantage. Okay. So when we have enough of the artery dissected free, and the goal is here to control the artery, right? It's proximal and distal control so that when you open the artery, there's not blood everywhere. And that can be accomplished either with small vascular clamps or bulldog clamps, and I'll put one on as a demonstration right now. You see the bulldog coming into the field, up on the vessel loop, and just using the bulldog there as a clamp. That can be done. Or we can do what we call a Potts loop, which is just essentially a double loop on the artery or the vein. So my assistant will come under from his side, come under the artery, and I'll take this end of the loop and pass it around so it's going around the artery twice. And there we go. And then we want to, so this technique will occlude the artery if it's a small enough artery. It doesn't work well on very calcified arteries or large arteries like the aorta. We'll typically use clamps for that, but it works just fine on brachial arteries and radial arteries. I should note here, before we come up on that clamp to occlude the artery, there's one thing that we want to do in most cases, in most anastomoses and vascular, and that's to administer heparin. And obviously the reason for that is to anticoagulate the patient enough so that they don't thrombose things distal to where you're clamped. You're creating relative stasis in the arterial bed distal to where this loop is, so we don't want the radial or ulnar arteries to thrombose. So we'll typically give heparin, and for larger anastomoses, we'll give as a standard 5,000 to 7,000 as a bolus, and then rebolus every hour or follow ACTs. Usually this takes much less than an hour, and so 5,000 should be more than adequate. When I do radial arteries, I don't even give heparin because there's great flow through the palmar arch from the ulnar side, and thrombosis is very low risk. Anyway, let's come under with a second Potts loop. So I'll grab the Potts loop. My assistant will come under the artery, and I will pass the loop once, and he'll bring it out to me, take that same end, and loop it a second time. Voila. Okay. Okay, there we go. And we've given our heparin, so all we really need to do is come up on our loops, and we have arterial occlusion. And normally the loop will slide on a native artery. It doesn't like to slide on this Penrose model, but it will work nonetheless. All right, so we're going to put a clamp there. All right, so we're up with both clamps now, and we have an occluded artery with a hole that I put in it. But we're going to incorporate that into our anastomosis, I believe. All right. Okay, we're going to take a little break and get ready for the real anastomosis. Okay, we are back live, and you might see that we've repaired our little hole here with a single purling suture. That was nice. All right, so now we are prepared to do the anastomosis. We have heparinized, and we have our artery controlled, and we have our vein divided and ready to spatulate for the anastomosis. So the first thing we'll do is kind of see how this vein is going to line up, and it's actually a pretty good length, pretty perfect length here. You don't want a lot of redundancy in it to introduce kinks or anything like that, and you don't want it to be under too much tension for obvious reasons, but this is a good length. So once we have that length, I'm going to have my assistant grab the other side of the anterior part of the artery, just roll it back toward him. And the one disadvantage of the Potts loop is that in a normal artery, it really sort of compresses the artery, and you have to take great care not to do what we call back wall. So when we make the arteriotomy, it's just using an 11 blade, we insert it all the way through the front wall of the artery and then lift up, kind of do a lift up technique like that. And you can see the white of the intima below there, hopefully. And then once we make that little arteriotomy, okay, then we enter that arteriotomy with the Potts scissors and slide the bottom half of the scissor in, and just kind of lift up slightly while making the cut with the scissor, and that will limit our arteriotomy to the anterior wall of the artery, which is ideal. Okay, and I'll extend it distally just a tiny little bit. So, length of the arteriotomy, obviously complications of steel include complications of fistulas rather include arterial steel, where too much blood goes into the fistula and not enough goes into the hand. And the ideal length of a arteriotomy for a fistula is somewhere between 7 millimeters and 1 centimeter at the most. Any larger than that, you really increase your risk of steel. And that obviously is a relative range kind of based on the size of the artery. So for a man, I usually make an arteriotomy 8 to 9. For a woman, 7 millimeters in length. And this is probably about 8 or 9. All right, so we have the arteriotomy. Now we prepare the vein. We're going to use the Potts scissors again. We already made sure that our vein length was good. So I'm going to grab my side of the vein, and we're going to do what we call spatulate, which is to kind of create a wider area on the anastomosis. So I'm going to use that Potts scissors and incise down the posterior side of that, and you can see as we flip it over that I've just made a venotomy on the underside of the vein. And now I'm going to grab the end of mine, Peter's going to grab the end of his, and I'm just going to take these corners off sort of to effectively create kind of a ovoid type shape, or some people say a cobra head anastomosis, kind of a hood, because that hood is going to sit right down on our arteriotomy, and that's going to be the anastomosis. And this is exactly how we do it in real life, except for tissue cuts a little better than that. Good. All right, so you can kind of see that we have sort of a cobra-headed shape. All right, perfect. Okay, so next we're going to start the anastomosis. By convention, we call, so if it's a cobra head, right, that's what Peter has up top here is sort of the toe of the anastomosis, and this back part is what we call the heel. So he's going to grab that side again and just open it. And I have here a 6/0 proline suture, and I'm going to go from outside the vein to within, right at the apex of our incision, or right at the heel. I'll re-grasp it. So now this needle is on the inside of the vein. So we want the knot to be on the outside of both the artery and the vein. So I take the same needle, which went out to in on the vein, and I'm going to go in to out on the artery at the heel of the arteriotomy. So Peter will let that vein just do what it wants to do, and he'll grab the arteriotomy, his side, and just open that up so that I can see the heel of what will be our anastomosis. And I take that same suture and I go in to out, taking about a millimeter worth of tissue for the bite. And again, that's relative to the size of the artery. When it's a very small artery, it will be a little less than that. If it's a big artery, like the aorta, you can be much bigger than that. Okay, so we have our suture in. Our knot is lined up, so it will be on the outside of the anastomosis. You want smooth surface on the inside and a non-thrombogenic surface, so obviously you don't want the knot on the inside. All right, and it needs to come through here. Make sure we're even. A little bit more. Okay. All right, now the assistant will take tension off the vein by guiding it over to the anastomosis while I make the knot. So again, I want to form the knot high and then use that finger pushing technique to drop the knot right there. There's one throw. Do another throw in the same direction to make sure it slides. You don't want an air knot on this particular knot, or really any knot. All right, and 3 knots will suffice because it's not a terminal knot. It's just the starting of our anastomosis. All right, so we're going to take a right angle, and I'm going to pass one end of the suture underneath the vein so that we can use that suture. It's a double-armed Prolene suture. We can use that suture to do the side opposite of me, and we'll do that right now. Okay, so here's our anchor suture in the heel of the anastomosis, and we will start the anastomosis. All right, let's take a pause for a second.